cancer. HPV, or human papillomavirus, is a sexually transmitted virus. It infects genitals, mouth, and the throat. It is passed on through genital contact. It is most often spread through vaginal or anal intercourse, although it is possible to contract HPV without having sex. At least 50% of people who have had sex will have HPV at some time in their life. Sexually active women less than 25 years of age have the highest rate of infection and get the most complications from HPV. There are more than 100 types of HPV, of which more than 40 can be sexually transmitted. Among these, about 15 are considered to be cancer-causing or high-risk types. HPV risk factors include genital contact, multiple sex partners, sex at an early age, history of sexually transmitted infections, failure to use condoms consistently, smoking, long-term use of hormonal contraceptives, co-infection with HIV, co-infection with chlamydia and herpes, low socioeconomic status or hygiene, diet low in antioxidants is a possible cofactor, and genetic and immunological host factors and viral factors. The human papillomavirus has a significant source of morbidity and mortality in the United States and worldwide. High-risk oncogenic HPV types, including HPV 16 and HPV 18, are associated with 99.7% of all cervical cancers, as well as low-grade squamous intraepithelial lesions. High-grade squamous intraepithelial lesions and abnormal Pap test results, which carry significant health costs and psychosocial morbidity. Low-risk HPV types, HPV 6 and HPV 11, are responsible for additional abnormal Pap test results as well as almost all cases of genital warts. HPV infection may be latent, subclinical, or clinical. It may take the pathway of low viral load infection without clinical disease or high viral load infection with clinical disease. Such disease may manifest as genital warts or as low or high grade intraepithelial lesions. Up to 90% of persons infected with high or low risk HPV clear the infection within about 2 years. In women, up to 30% of cases of genital warts spontaneously regress within 4 months. It is not clear whether the immune-mediated regression eliminates the infection or suppresses it permanently, but in either event, the virus ceases to manifest lesions. The small minority who fail to clear the infection are at risk of progression to cancer. The peak prevalence of HPV infection in women occurs in their early 20s. After women reach 20 years of age, the prevalence steadily declines, although a smaller second peak occurs in postmenopausal women in some geographic areas. This may be attributed to viral persistence or perhaps new acquisition. The interval between infection and diagnosis of cancer is 10 to 20 years because the peak incidence of cervical cancer does not occur until 40 years of age. Testing for persistent HPV infection is most useful between 30 and 40 years of age. The two most common types of cervical cancer worldwide are squamous cell carcinoma, followed by adenocarcinoma, and they are both caused by HPV. The CDC and National Cancer Institute's United States Cancer Statistics Working Group reports that from 2005 to 2009, there were annual averages of 12,595 cases and 3,968 deaths due to cervical cancer. HPV is believed to be responsible for nearly all of these cases of cervical cancer. HPV types 16 and 18 are associated with 70% of these cancers. The worldwide incidence of cervical cancer is approximately 510,000 new cases annually, with approximately 288,000 deaths worldwide. Unlike many other cancers, cervical cancer occurs early and strikes at the productive period of a woman's life. The incidence rises in 30 to 34 years of age and peaks at 55 to 65 years, with a median age of 38 years. In addition to cervical cancer, HPV is believed to be responsible for 90% of anal cancers, 71% of vulvar, vaginal, or penile cancers, and 72% of oral pharyngeal cancers. Abstinence is the most effective preventive method for HPV. However, the FDA approved 2 HPV vaccines. The quadrivalent recombinant HPV vaccine, also known as Gardasil, protects against HPV types 6, 11, 16, and 18, and was approved in 2006 for girls and women 9 to 26 years of age. It prevents genital warts and cervical cancer and is given as a series of 3 vaccinations at months 0, 1, 2, and 6. The bivalent HPV vaccine, Cervarix, protects against types 16 and 18, but not types 6 and 11. It is approved for girls and women 10 to 25 years of age and is given as a series of 3 vaccinations at months 0, 1, 2, and 6. Controversy about HPV vaccination involves its high cost, it's approximately $150 per injection, uncertain duration of protection, and concerns that it provides approval of sexual activity and a false sense of security. In addition, the necessity of vaccinating girls at a young age before they become sexually active unsettles many parents. There has been criticism for aggressive marketing of HPV vaccine to older women already exposed to HPV, while less attention has been given to the subpopulations at highest risk. In areas where cervical cancer screening is already routine, HPV vaccination will only significantly decrease the number of women who get cervical cancer, only the number who have abnormal screening tests. The social and emotional distress of having genital warts or HPV is far worse than the physical symptoms, especially upon first discovering that you have been infected. Some people suffer from depression or anxiety because they fear recurrent outbreaks, transmission to sex partners, or difficulties developing new relationships. Implications of HPV with pregnancy. Currently, there is no link between HPV and miscarriage or premature delivery. It appears that HPV does not cause any complications during pregnancy. If you have genital warts when you become pregnant, your doctor will just monitor their possible growth during your pregnancy. You go through a range of hormone changes during your pregnancy, which may cause the genital warts to increase in size and number. Usually, treatment or removal of the warts is delayed until after you give birth, except in extreme and rare cases. If your doctor thinks that your genital warts could interfere with the delivery process by obstructing the vagina or cervix, they can be safely removed by surgical means or by laser. The risk of transmitting HPV to your baby is low. In most cases, if the baby is infected with the virus, their own immune system clears it from their system. In extremely rare cases, the virus can cause respiratory papillomavirus in the baby, which is a more serious form of HPV, where warts grow on the throat and respiratory tract. There are 2 schools of thought about the wisdom of a cesarean section as a way to prevent HPV transferring to the baby during labor. Some doctors believe it is a valid strategy, while others believe that Because the risk of transmitting the virus to the baby during birth is so low, the risk of surgery outweigh the potential risk of HPV infection. However, statistics show that the majority of pregnant women who have had HPV or genital warts have a perfectly healthy pregnancy and uncomplicated delivery. Most women who have the virus through pregnancy likewise experience no symptoms or difficulties. Approximately 6.2 million new HPV infections occur every year in the United States, and approximately 20 million individuals are currently infected. The Centers for Disease Control estimates that at least half of all sexually active individuals will acquire HPV at some point in their lives, whereas at least 80% of women will acquire HPV infection by age 50. In the United States, it is estimated that 10% of the population has an active HPV infection. 4% has an infection that has caused abnormalities, and an additional 1% have an infection causing genital warts. In 2011, an estimated 12,710 women suffered from cervical cancer, and 4,290 died from it in the U.S. HPV vaccination, HPV, and PAP screening could reduce this burden. Using 2010 National Health Interview Survey data, current disparities in the use of PAP screening and HPV vaccine in U.S. women aged 18 to 30 years were investigated. The sub-analysis focused on unvaccinated women. The sample had 3,129 women aged 18 to 30 years, representing about 27 million women of similar age in the U.S. The PAP screening and the HPV vaccination initiation and completion rates were 53.5%, 17.9%, and 10.3%, respectively. Hispanics were 33% less likely than non-Hispanic whites to initiate HPV vaccination. Non-Hispanic blacks were 55% more likely and 57% less likely than non-Hispanic whites to receive PAP screening and complete HPV vaccination, respectively. Non-Hispanic Asians were 36% less likely than non-Hispanic whites to receive a PAP screening, but this result was borderline significant. Younger age and being unmarried were predictors of lower PAP screening but higher HPV vaccination. Ever gave birth was a predictor of higher PAP screening but lower HPV vaccination. Preventative behaviors were predictors of higher HPV vaccination. STI history was a predictor of higher HPV vaccination and PAP screening. Not having health insurance for over 1 year or recent health provider visit were predictors of low PAP screening and HPV vaccination. Living in the South was a predictor of lower HPV vaccination. Household income was not a predictor of any outcomes. Most common reported reason for no HPV vaccination was there was no need. Study findings indicate interventions to mitigate disparities in cervical cancer prevention are needed. Tailored education, interventions for both women and healthcare providers, along with opportunities associated with the 2010 Affordable Care Act, such as broader access to healthcare, emphasis on health information technology, and initiatives for PAP screening and adult vaccination as potential quality indicators for performance payment can reduce these disparities. HPV and cervical cancer in India. Cervical cancer is ranked as the most frequent cancer in women in India. India has a population of approximately 365.71 million women above 15 years of age who are at risk of developing cervical cancer. The current estimates indicate approximately 132,000 new cases diagnosed and 74,000 deaths annually in India, accounting to nearly 1/3 of the global cervical cancer deaths. Indian women face a 2.5 cumulative lifetime risk and a 1.4% cumulative death risk from cervical cancer. At any given time, about 6.6% of women in the general population are estimated to harbor cervical HPV infection. Cervical cancer in India. Approximately less than 200 women die every day from cervical cancer. 8 women die every hour, and every 7 minutes a woman dies. Cervical cancer is the leading cause of cancer-related mortality among young women in India. However, participation in prevention and screening is low, and the reasons for this are not well understood. In a cross-sectional survey in August 2008, 202 healthy women in Karnataka, India, completed a questionnaire regarding knowledge, attitudes, and practices related to the human papillomavirus and cervical cancer. Factors associated with vaccination and pap smear screening acceptance were explored. 36% of women have heard of HPV, while 15% have heard of cervical cancer. 5% of women reported ever having a pap smear, and 4% of women felt at risk for HPV infection. 46% of women were accepting of vaccination, but fewer were willing to have a pap smear. Overall, knowledge related to HPV and cervical cancer topics was low. Women with negative attitudes toward HPV infection were 5.3 times more likely to accept vaccination, but were not significantly more likely to accept pap smear. Cost and a low level of perceived risk were the most frequent factors cited as potential barriers. Improving awareness of HPV and cervical cancer through healthcare providers, in addition to increasing access to vaccination and screening through government-sponsored programs, may be feasible and effective methods to reduce cervical cancer burden in India. Outside Africa, India has the highest number of people living with human immunodeficiency virus, otherwise known as HIV. HIV is known to increase the chance of acquiring and the persistence of oncogenic HPV. In immune-competent female subjects, an HPV infection starts appearing in the genital tract following first sexual exposure and is understood to be cleared off with increase of age, and mostly by the age of 30 year, as revealed by some studies. However, the natural history of HPV infection is known to be altered in persons infected with HIV, and there is an increased possibility of persistence of HPV infections in this population. This data is necessary to understand the epidemiology of oncogenic HPV among female population with and without HIV and its additional infectivity caused by HIV infection, if any. The odds of having HPV infection were 4.9 times higher among HIV-positive women than HIV-negative women. Generally, HPV prevalence in women shows a peak at younger ages and then declines over the age of 30 years. There is no clear peak of HPV prevalence in young women. However, it should be noted that in these studies, and also in the current study, subjects included were primarily married women. This is because in India, genital tract sampling of an unmarried woman is associated with cultural and social taboo. Socio-cultural practices specifically related to Indian married women might have played a role in the lack of peak in HPV prevalence among younger age groups. Number of lifetime partners, sexual behavior patterns, number of pregnancies, genital hygiene, presence of other STDs, socioeconomic conditions, literacy status are all factors that contribute to India's high HIV, HPV, and cervical cancer rates. The Mumbai study. Some researchers argue that the cost of PAP and HPV tests are a barrier in India. India does not have the funds and laboratories to provide Pap smear screening to these poor women. The purpose of the Mumbai study was to see whether the method known as visual inspection with acetic acid or VIA could provide a viable alternative in developing countries. In VIA screening, a trained worker swabs an acetic acid solution on the cervix, then looks for abnormalities, such as precancerous lesions, which turn white when exposed to vinegar. The Mumbai study divided more than 151,000 women into two groups. Women in the study group underwent 4 rounds of screening with acetic acid over 8 years. They were provided free treatment at Tata for any abnormalities detected. Researchers put half of the women in their study, more than 76,000, in a control group. Those women were not screened or routinely treated for cervical cancer, but were monitored as their cancer progressed, and at least 98 of them died. The control group had not been properly informed and had not been given adequate informed consent. Ethical considerations regarding HPV. One of the main controversies surrounding the cervical cancer vaccine is the issue of pediatric decision-making. Parents must consent to their daughters receiving the vaccination. Oftentimes, the daughters are old enough to assent and may disagree with their parents. As children age, the balance changes from surrogate decision-making by their parents on their behalf to their own ability to make informed decisions. In many states, reproductive care is considered confidential for adolescents and does not require parental consent. Since HPV is sexually transmitted, questions arise as to whether this may cause children to engage in high-risk sexual activity, since there is a perceived protection from some of the ramifications. However, high-risk behavior can lead to a number of other sexually transmitted diseases, pregnancy, and emotional complications. Due to the oftentimes personally, politically, and culturally sensitive nature of reproductive diseases, research and treatment is often lacking compared to diseases that are not sexually transmitted or do not affect the reproductive organs. Proper education on HPV and cervical cancer would reduce outbreaks. Making Pap smears and other early detection advances available to women would reduce HPV and cervical cancer outbreaks. There are many support groups available for women diagnosed with HPV and or cervical cancer that are successful in helping the women that are diagnosed. And these are my references.